Hello, I am Mark LaBarbera, and this is a cardiac arrhythmia video that I've made up. This is uh, targeted towards 214 nursing students in a 2-year nursing program. This video is for educational purposes only, not intended to be any medical advice. Um, Numbers and thinking always changes. Protocols change. If you have any questions, please consult your teaching faculty. We'll start off with parts of the QRS. You have the P, QRS, T wave. There's a U wave in there, but don't worry about U waves. Starting off with the P wave. P wave is the initiation of the cardiac cycle, electrical cycle at the SA node. SA node fires, travels down through the atrium to the AV node, through the AV node, and you get this giant spike where depolarization of the ventricles occurs. The ventricles are get this electricity going through them. They contract, and then you move on to the T wave. T is repolarization, resetting of all those cardiac cells for the next complex. So we'll start with the P. Again, we said the P has to be upright, round, 1-to-1 with the QRS, has to be a certain distance away. The PRI has to be consistent. If it's too close or too far away, it's indicative of disease. If it's variable, it'll also be indicative of disease. So normal PRI is 0.12 to 0.2. That's pretty standard. Or 3 little boxes, greater than 3 little boxes, and less than 1 large box. The boxes, when you look at them, 1 little box is 0.04 and 1 large box is 0.2, and these are standard throughout all EKGs, all different manufacturers, pretty much the world over. Q restoration is how long it takes the ventricles to have the electrical impulse travel through them. This should be fairly narrow. Should be less than 0.12. If it's wider, it's indicative of disease. And then in this video, I'm also going to be covering the QT interval. This is going to be new. It's not going to be something that typically nursing 212 students or 214 students learn about, but I think it's pretty important because there's some medications and some considerations that we need to take into account when we're looking at the QT. So why is QT important? Like I said, there's a bunch of medications that we give. If you've been going through school and looking at the adverse reactions, you'll see QT elongation. We've never written it down as a serious complication, but it could be, and it's something to more take into consideration, especially if the patient has a predisposition for this. So medications that can cause a prolonged QT that we would give: amiodarone, procainamide, sotalol, erythromycin, haldol, olanzapine, risperidone, amitriptyline, sertraline, and venlafaxine, and others. But those are some of the ones that we've been dealing with in class that can potentially cause problems with the elongated QT. There's also a genetic factor that predisposes people to have problems with elongated QTs. This hopefully would be discovered by a provider well before you got hands on them, but if you see this, it might be something to bring up to a provider to take a closer look at if they didn't know this was happening. So why are we concerned about prolonged QT? This is kind of the T wave is repolarization of the cardiac muscle, getting ready for the next cardiac cycle. This is where all the cardiac cells reset, get ready to be depolarized and contract and send the signal down the line. So if you stretch this out and you make this longer and wider than it should be, you get this impulse that goes through the QRS and it goes to the T wave, and the T wave starts to reset. But since the T wave is so long, it takes a lot longer for all these cardiac cells to repolarize and reset. So the ones at the beginning on the left-hand side um, repolarize right away, and they're all already ready to depolarize once they've been repolarized. The stuff on the right side of the elongated T wave hasn't repolarized yet. So if the cells on the beginning side, on the left side of the T wave, depolarize for some reason, they're going to start depolarizing. They'll eventually catch up to the right hand side of the T wave that is just becoming repolarized, and trigger those to contract and send a signal further on. And this ends up being kind of like this continuous electrical depolarization, kind of the electrical depolarization chasing its own tail around the heart again and again. And this ends up going very, very fast. And we get what's known as torsades de pointe, or turning of the points, or polymorphic ventricular tachycardia. And this is kind of a stylized look at torsades, as you see on the screen below us. But you can see on the left-hand side, you get these kind of big curves at the top and points at the bottom, and it goes in this kind of crescendo, decrescendo type rhythm, where you get decrescendo going down to this point on the left-hand side, then starting to build up, crescendoing up, and the points are now towards the top. It gets to a big point, starts decrescendoing down. You see points down at the bottom. So this is turning of the points, and it might not be nearly as painfully obvious as this is, but this is torsades, and it has to be treated a little bit differently than VTAC, because this will sometimes look very much like VTAC with very subtle changes. Ready for some EKG interpretation? Okay, this is a fairly easy one. Take a look at your EKG. We'll do rate, PRI, QRS, QT interval, and then kind of the overall name of that rhythm. If you need to take longer, you can go ahead and stop the video and count everything out, and then press play to continue the video again. So we're looking at the P wave. Is there a P wave before each QRS? Is it pretty uniform? Is it upright, rounded, within a normal distance, not too close, not too far away? We'll look at the rate, and if you look up at the top, you can see little red hash marks up at the top in the white area just before the picture is cut off. And those are 3-second hash marks. So take 2 of those, count the complexes within those 2. Don't split any complexes, because that's going to throw off your measurement. So measure those up, count those up, and then take a look down at the bottom right, and this is a blow up of one of the complexes, and this makes it a little bit easier to count the small boxes. They're 0.04 each. So count the beginning of the P wave to the R wave, or where the R wave would be on an EKG, on a QRS complex. Count that up. That's your PRI. QRS, measure from the R wave to the end of the T wave, beginning of the beginning from the R wave, or where the R wave should be, to the end of the S wave, where the T wave starts, and measure that. And then the QT wave, measure from where the Q is, or where the Q should be, to the very end of the T wave. And that's going to be quite a bit longer, but measure that. If you need more time, take your time. So the answer is a rate of about 60, PRI of 0.2, which is normal, QRS duration of 0.04, which is normal, a QT interval of 0.38. And right now I'll tell you, the QT interval is fairly difficult to calculate. There's no real consistent way that people calculate it. The best I can say would be have the computer do it for you, have the EKG machine do it for you. They'll give you a consistent number that can be used throughout your hospital or throughout your office. They have a QT and corrected QT. Corrected QT uses like square roots and stuff. the QT, they recommend doing like an average of 3 different complexes, and then doing a R to R and dividing that in half and stuff. So a little bit difficult to do all the calculations. A lot easier just to read it off the printout of your EKG machine. So the next one here, this looks like it's going a little bit faster. Look for your 3-second hash marks at the top of the page and go ahead and calculate the rate. And then look down at the lower right and you can measure up your boxes. Remember 0.04 is a small box and 0.2 is one of the large boxes. So measure those up and take a look and say, is there a P wave up round 1-to-1 with each QRS? Is it a consistent distance away from the QRS, not too close, not too far away? Is the QRS narrow? Is it a consistent distance between the next QRS? Is there any arrhythmias? And when you have all that measured up and everything, you can continue. And we'll go to the next slide. So this rate is about 100. That's what I got on the computer told me. PRI is 0.14. Q restoration is 0.07. QT interval is 0.4. And all these numbers look pretty good. So we're going to call this sinus tachycardia because it has a P wave. It's initiated from the SA node. And it's 100 beats a minute or over, so this is tachycardia. Next rhythm here, I've already kind of written in the rate up at the top in light blue because this rhythm is irregular. So depending on where you measure from and to, you may get a fairly wide degree of change from what rate you're going to see. So this is an irregular rhythm. First, go ahead and look for your P waves. And this is kind of a trick question because there aren't any P waves, especially if you look at the some of the wider spaces between two of the complexes. You can see that there's really no single nice rounded 1-to-1 hump that would be a P wave. You can still measure the QRS. So if you look down at the bottom right, you can measure the QRS, measure the QT out. And when you're done. So this is a rate of 105 about. This is what the computer calculated it at. There's no PRI because there's no P wave. There's a lot of foci in the atrium that are all kind of competing, and every so often one gets through the AV node down to the ventricles and causes a contraction, but it's nowhere near consistent, which is very indicative of atrial fibrillation. Atrial fibrillation is generally stated as being irregularly irregular. There's no consistency to it. There's no 2 beats and then a pause, 2 beats and a pause. There's no a beat, a pause, a beat, a pause, anything like that. There's no rhythm whatsoever to it. So even if you were to not have an EKG available and check a radial pulse, if you have an irregularly irregular pulse, you can consider that the person may have atrial fibrillation. Maybe start looking at medications to see if they're on anything for atrial fibrillation, or ask the patient, have you ever had an irregular heartbeat? Have they ever treated you with medication for it? And it may be new, but something to consider. Next, EKG is also looking a little irregular. Rate of 49 is what the computer calculates it at. So look at the lead 2, that's the top lead there on the page, and look for P waves, and you don't really see any P waves. And actually, this actually looks a little sawtooth-like. Sawtooth is pretty indicative of atrial flutter, and it has to be a certain rate, but when you hear about sawtooth waves, and if you go further into study of EKGs, you'll understand kind of what the sawtooth means, and it's a little bit different from atrial fibrillation, but it's the same. It's like a cousin of atrial fibrillation. So it looks irregularly irregular. No P wave that I can see. There's a lot of maybe fibrillation waves, or F waves, I call them. Look at the bottom right. You can measure the QRS, measure the QT, and when you're ready, we'll name that rhythm. So I'm going to call it atrial fibrillation. It might be atrial flutter, I don't know. There's no PRI because there's no real P wave visible. QRS is 0.07, which is okay. QT interval is 0.38, and I'm going to call it atrial fibrillation. Okay, this is the next one. This looks fairly alarming. Looks quite fast. And this particular tracing is a little deceiving. If you look at the left-hand, most of the left-hand side of the tracing, it looks fairly wide, and you might want to say, especially if you're looking at like AVR or V1, that this might be VTAC. And it's not. If you look at the bottom right, maybe V5, V6, concentrate on that. That's more of a good representation of what we should be looking at. It's narrow complex. It's a pretty fast heart rate. There is a trick to doing a heart rate if you don't have a good 6-second strip, or you don't know where a 6-second strip is without counting all those little boxes. It's a 300, 150, 100 rule. You count the big lines between the big boxes, and the first line after the complex you're counting is 300, 150, 100. So if you count bottom right, find a complex that is right on the large line. Next line over is 300 beats a minute. Next one past that is 150. So the complex is a little over, is halfway between 150 and 300. So it lets you know it's greater than 150, probably a little closer to 300, maybe less than 300, but it's pretty fast. You can't really tell if there's any real P waves or T waves because they're all kind of mixed in each other. So we're going to look at the rhythm. The computer gave it a rate of 223. You can't tell a PRI because it's going so fast. QRS, the computer gave it 0.16, and QT interval is 0.212. This is paroxysmal supraventricular tachycardia. Paroxysms are fast initiations. This rhythm didn't start out slow, didn't start out at 70, go to 80, 90, 100, 150, 200. It was going at 70 1 second and 200, 230 the next second. It started very fast. And this is similar to the previous torsades that we were talking about, where this electrical activity keeps circulating around the heart. This isn't nearly as bad. There may still be a pulse rate, although this patient really didn't feel good. Diaphoretic, shocky looking, pale, low blood pressure. And we know it's supraventricular because the complexes are narrow, especially in the lead 5 and V5 and V6. If they were wide, we'd probably call it either aberrant, which is something for advanced cardiology, or ventricular, because the ventricles are much bigger. They have a lot more nerve pathways. The Purkinje fibers and bundle branches and stuff, they're much more of a mass, so they give a bigger spike. But this is supraventricular, coming from the above the ventricles. Tachycardia because it's well above 100. It's actually above 200. Here's another one. Here's some irregular beats in here. And if you start off by looking at the P wave, probably look in the lead 1, which is the center EKG strip here. You'll see you do have P waves. They are pretty consistent for the most part, except these little extra beats that are placed in among them. So this is a underlying sinus rhythm, and the box at the lower right is representatory of the baseline rhythm. You can count that if you want to. These extra large, wide, bizarre beats at the top, especially, they don't all look exactly the same. The first two maybe look pretty close to each other. The third one looks a little bit smaller, not quite the same as the first two, and the one all the way to the right looks a lot different. So what's happening here? So computer gets us about a rate of 97. So it's not tachycardia, it's sinus. It's a sinus rate because of the P waves and underlying rhythm. But then we have these extra beats, and these are PVCs, premature ventricular complexes. And I want to remind people that these are complexes, not contractions. This is only looking at electrical activity and not actual physical heart motion. And they're called multifocal because they're coming from different foci. The first two may be coming from the same foci because they look fairly similar. They're going through the same conduction pathway. The third one, just to the right of the center line, looks a little bit different. It's probably close to the foci that the first two had, but it looks a little bit different, probably the electricity is going at a slightly different direction through the ventricle. So that looks a little bit different. And then the last one on the far right looks very different. It's very small. Like I reminded you earlier, the ventricles are real big, have a lot of muscle, have a lot more Purkinje fibers and bundles and stuff. So the complexes are going to be kind of big, and because these aren't necessarily going through the bundle and everything as efficiently as they should, they're going through a foci outside of that normal conduction pathway. They're going to be wide because they have to take more time to travel through the heart muscle, and this would also be seen on, like, when you get into advanced cardiology, you hear about bundle branches or heart blocks. You start getting kind of a wide complexes with that too. And because the rhythm of these is every third beat you get a PVC, 3 is tri, so this is trigeminy. If you had a PVC every other beat, it would be bigeminy. So this is kind of interesting. This is a period of trigeminy, multifocal trigeminal PVCs. If you were to feel the pulse as you were watching this, these PVCs probably wouldn't give you much of a peripheral pulse, if any at all. This is because the ventricles haven't quite filled up fully. You may still have some atrial contraction into the ventricles, and the ventricles fire. They're not quite full. Some of the blood may go back up into the atrium, and you don't really get a good peripheral pulse with these. Here's another one. It's another irregular rhythm here with some unusual looking gentleman in the middle here. So underlying the rhythm, look for P waves. Are they upright, round, one-to-one with the QRS? And I would say for the most part they are, with a few exceptions here. Take a look at the bottom right, and you can count out the numbers if you'd like. And then we have these kind of 3 things in the middle, and then one additional one over to the right there. So this is a patient that I had a few weeks ago, and he didn't feel this. He didn't feel any different, but I was a little concerned, and I was kind of waiting to see what would happen. Didn't give him any medication at the time, but I was thinking about the possibility of giving him some antiarrhythmics if he started to do more of this. So ready for the answer? Rated 99 from what the computer calculated. PRI of 0.12, QRS of 0.08, QT interval of 0.34, and because this is 3 PVCs in a row without any baseline complexes in between, it's called a non-sustained ventricular tachycardia. Any more 3 or more complexes like this in a row, it's ventricular tachycardia. Not enough to really do CPR on or have the person pass out and go into cardiac arrest. If it continued like this, that may have been a possibility. So you have an additional PVC over there to the right. You could say it's non-sustained VTAC with multifocal PVCs. And I would imagine if I was feeling the pulse right here, that when this non-sustained VTAC happened, you would have a long pause, probably almost a 2.5, 3 second pause, which would be concerning. But it wasn't enough for the patient to feel, and he didn't do any more of these, so we just kind of watched him closely for any changes and made sure he didn't have any chest pain or anything. How about a case study? This is kind of a fun one. Another rhythm that I didn't really get to record for you guys, but fortunately someone that I'm very close to had a little arrhythmia, and I was able to catch it and give you some background and stuff. So here we go. So our patient is a 47-year-old male with a high-stress work environment, sleep-deprived in nursing school, and drinks 1 large coffee and usually 1 energy drink a day. For several days, he's had a feeling of fluttering in his chest from time to time, and when he felt his pulse, he noticed that when he had the fluttering, he had a irregular pulse. So you put him on the EKG, and you see this. So let's go back to, is this sinus? Is there a P wave? Is a P wave round, upright, and 1-to-1 with each QRS? And it looks like it is. The P waves might be a little bit peaked, but I don't think that's overly concerning. If you look down the lower right, you can measure out the QRS if you'd like. So what's going on here? You have a fairly regular rhythm, but just to the left of the center of the page, you see one complex. Looks like the others, but it's a little bit closer. Maybe something fired a little bit early. So what happened here? So the answer is this is a PAC, premature atrial complex. And what happened was the atrium fired, everything's going okay, and soon after the atrium fired, the atrium fired again fairly quickly, kind of asynchronous, faster than it should have, and it gave maybe a little bit longer pause while the heart was catching up to itself. We know it's atrial because it's a narrow complex. It looks pretty similar to the rest of the beats. You may notice in the lead 2 at the very top, the PAC has a little bit of a notch that may be indicative of the electricity reaching the positive electrode on the surface EKG at slightly different times. Interesting, but not overly concerning. The P is upright in these, and having one of these every so often, having a PVC every so often, is not overly concerning. Everyone has them. If you ever felt like your heart pounded or rebounded or you had a little fluttering, you're probably throwing a PVC or a PAC. If you have a lot of these, you may want to see your doctor or call a provider to take a look, especially if they're numerous per minute. Okay, this is the end of our video. I have 2 books to recommend to you. One book I highly recommend myself is Dale Dubin's Rapid Interpretation of EKGs. It's the orange book. This book is excellent for teaching the basics of EKGs. Very easy read. Has a lot of pictures in it. Very easy to learn from. You read this over a weekend and you know pretty much everything you need to do the basics of EKGs, way more than we would learn in our class. On the right hand side we have Henry Marriott's Bedside Cardiac Diagnosis. Not really a true EKG interpretation book, but cardiac diagnosis at the bedside. How to use your stethoscope to assess the heart, how to use your hands to diagnose the heart, feeling for different kinds of pulses, different places, what that pulse means, how to better take a blood pressure. I've had great success in the past getting both a systolic and diastolic blood pressure by palpation, and that's what this book taught me. But two excellent books. If you want to learn more about EKGs, I'd highly recommend getting Dubin's orange book. That's it. Thanks for watching. Please share this video. If you're looking for more videos, look up Medical Education Depot on Facebook. That's a site that I've been using or been part of, and to go ahead and teach others what you know. Thanks for watching. Have a good day.